It has come soon. Sometimes it has come.
So good morning, everyone, and I welcome you all for this the first ever national nationwide initiative of DIPSI. Hello. Yeah. Can you just mute Dr. Seshiah's volume?
Yeah, we are muted.
Yeah. Yes. So I welcome you all. I welcome you all for this meeting, which is a first is of its kind on mass awareness program under the banner of DIPSI, which is being named as Diabetes PregaTalk. Now, this Diabetes PregaTalk has been started at a national level, and DIPSI is dedicated for having public awareness about this particular issue, Diabetes PregaTalk. And today we have the first episode, which has been dedicated to our founder of DIPSI, founder patron, Bhishma Pitamaha of DIPSI, the person who has got wonderful work in the field of diabetes and pregnancy, pioneering work since last almost 4 decades or 5 decades. I welcome Professor Seshiah, who's with us for this particular program. And let me share with you, dear, this program is going to be a little different. We are going to understand from Professor Seshiah, who has actually started the first diabetology department in the country in Madras Medical College. And he had also started in 1980 the first fetoplacental unit of he realized that there is some relations of non-communicable diseases like diabetes with the intrauterine environment or the metabolic environment when the fetus gets developed. And he has come out with something which is very, very rare to all of us. There's some concept that Indian women are more likely to have diabetes, and these women, if the blood glucose can be controlled to the extent that the blood glucose fasting remains 90, postprandial remains 120 2 hours. If you do this, we can protect the next generations to become diabetes. And these mothers who are having GDM, they are also likely to become diabetes in future, and they can also be protected. So his basic mantra, if today with the punchline of DIPSI of this program, is focus fetus for future. Focus fetus for future. Sorry, sir.
Sunil, please use focus on the fetus for the future. Focus
on the fetus for the future. So we will have the person who is legendary in the field, and we'll have a different kind of interview, sir, from you, because this is the first program of DIPSI. We want to understand from you how your journey has started, how you as a medical student earlier, and then you become graduate, and then you have taken over. You had been to army. You have participated in Indo-Pak war. And then thereafter, you again came back and worked in a government setup for almost 30 to 40 years. And then in there itself, you started this journey of first diabetes and then focused area of diabetes and pregnancy. Over to you, sir. How this started? What are difficulties you have faced? And how a young generation should be following you on these lines?
Good. Anyway, I will tell you my story, my life story, or autobiography, or biography, whatever may be there. I passed out of medical college in 1962. At that time, I won't know where to go. Should I serve the country, state service? I have no idea at all. At that time, I was doing my citizenship. That was the time when Indo-China war started. That Kavanlai came. He made a great friendship with our Prime Minister Nehru those days. And Nehru thought he's a chindi chini bye-bye. And he never knew. And I tell you this story, what happened. Then we had a defense minister called V.K. Krishna Menon. He's little communist oriented. Because whatever we there. So he's a great friend of our Prime Minister, Mr. Nehru. So all of them believed Chavan, I thoroughly believed. And then suddenly in 1962, they attacked in the Himalayas, close to Tong area, some area, I don't have to say. Nevertheless, what happens, you're taken with surprise. They're not undeclared war. Many of our Indian soldiers not prepared. They're not well equipped for the winter. So many died and many became prisoners. So, okay. That is the time the general of the medical service in the army, General Menon, he came to Chennai. I think he's the old student of paramedic college. So he came and he addressed us about told the problem, and he wanted people to join us, volunteer to join the army. So I thought, why not I join? Why should when the country needs somebody's support? So I applied for the army. The military selected me. I was very healthy those days. So since 3 I was commissioned in the army. I was sent to Lucknow for the what do you call it? You have to know what is procedures in the army. So 2 months I was in Lucknow. Then I was promoted as lieutenant. That is first what do you call decoration they give. Then when I became lieutenant, then I went to Belgaum, the Belgaum Military Hospital as an officer. 1 year I was there. Then what happened? Then they shifted me to, usually they call it sent to field areas, J&K. So I don't know how people know about J&K area. I went to Pathankot, we went to Samba, one area is there, then Udhampur, then we went to Jammu, then Kashmir. So I was moved here. First I went to Samba, then I moved to Udhampur, then I moved to Jammu. From Jammu we have shifted to Kashmir. And on the way, my leave came. See, in the army, they always give 2 months leave, vacation every year. So I was in Chennai at that time. Then that is the time Indo-Pak was started. When I was in India, Chennai on leave. Then those days we don't have the cell phone or nothing like that. TV, there was a TV announcement only. TV announced saying that the Pak army is attacking Indian border. So those officers who are on leave, please join back. So I had to return back because it's the middle of the leave. I went first. The train goes to Pathankot. From Pathankot, we had to go bus to Jammu. When I went to Jammu, some English movies will see, when the war is there, whole city will be deserted. Nobody will be there. So I was finding Jammu almost vacated. And still I had to proceed to the Srinagar. That is not beyond Srinagar must go. So there's only way of traveling from Jammu to the Srinagar, and then field area is only by lorry. The trucks, they call trucks. And the truck only whole day you have to travel the truck, there's so many miles. Anyway, it's really a tough job to travel those days. I reached that particular point that is called, I was supposed to climb on height called Bedori height. They said, sir, you have to reach same day, you can't take any rest in this. I walked. Because I was a healthy person, I could walk. Anyway, I reached that height. Bedori height, that is 13,000 feet height. That is called near the Uri Punj Bulge. That's the height called Bedori height. After the Bedori height, you see the Pakistan. You can see the Pakistan troops that side. So when I went there, I wish some people would have seen the English movies. They called bivak, not the when you have to sleep, not the tent. You have to crawl. This bivak will be about 2 feet high. That's all. You have to crawl inside and go and sleep if you want. That's all it's anyway. So the war was going on, Indo-Pak war. Then it took 2-3 weeks, the war was over. Then we returned to Rajouri area. Then 1967, the war, the 4 years service was over. I was not opting for the permanent commission or for the I opted for the emergency commission. Short service commission means 5 years, but I said no, I went back. So I came back to Chennai. I joined a government justice institute for 3 years. Then I did my MD. After the MD, that is the time. What happened when I was army? My elder brother, Dr. Perumal, he developed diabetes. I was really a little worried. So why you got, then that is the time the consultant told you take insulin. There's no other way. So that time I hear what else we can do. This is a that's how, because brother was my guide. He only guided me everywhere. So when he got this diabetes, I was little shocked. I said, let me do something on this field. Then anyway, by the time I came, I was not given any posting in the college. So then after the chest institute, I joined MD General Medicine. I did General Medicine in Stanley Medical College, Chennai. Then I was posted as assistant professor in the Kilpa Medical College. I was waiting for the chance to go to under Moses, for Moses. That time Vishwanathan were both known those days as a diabetologist. So Vishwanathan was in the service, but by the time I did the PG, he left the service. He went into his own practice. So by fortunately, I was able to get into Dr. Moses' unit. I was working there. That is the time I put the request for the Moses, sir, I would like to develop the diabetes department. And he was very happy that somebody is able to accept my ideas. So he gave 5 beds to start with. 5 beds were given for diabetes. I started there. Slowly within a year, and we developed a department, 30 beds. That is time I had applied for the government for to start a department of diabetology, separate department. And with the government, lots of procedure with it. I don't want to waste your times. All the procedure, diabetes investigation, health secretary, health minister, then chief minister, all the process will take at least up and then I can go down like that. I think if somebody worked in the service, you know what is the problem. Anyway, ultimately, department was started. A number of people wanted to become head of the department. So lots of Halaguda was there. Fortunately, the secretary who knew what is happening, he said, I would like to promote only Dr. Seshiah as a reader. So I was promoted as reader in 1978, first time. Then one year I became professor. That is over. Department of Diabetology started. Then 79, I went to Vienna IDF conference. Myself and Professor Moore, we both went. Then we were discussing about the problem of this pregnancy and diabetes. Something it is, I don't know how the topic came in. Some photo was there, you know. We were both sitting in a ship, the boat, having a dinner, a cruise dinner. Then he suggested, why not you go to Aberdeen? Aberdeen is supposed to be a very good place for the pregnancy diabetes. The unique thing in that center is, nowadays what you do, if somebody comes to you, Sunil Gupta, he will see, and he'll send you to obstetrician. Different places they'll go. Whereas there, that hospital, Aberdeen hospital, physician and obstetrician sit together and see the pregnant woman. They decide what problem, what progress was made, how to proceed with the treatment. So I thought it's a very unique way of doing that. I came back 1980, and as Vijay was telling, the Institute of Obstetric Gynecology, we started the first thing we got named feto-placental maternal unit. Because that is what those days known as maternal, fetal, that's our unit. All the, that womb doesn't mean it contains placenta, fetal, and maternal. After a few months, we found difficult to pronounce this word, feto-placental maternal unit. Then I said, okay, we make it simplified. We call diabetes pregnancy unit or service. So it was going on. That is the time when we went to these records, hospital records, we found fetal wastage. How many children, fetus don't survive? We were surprised to find that is in analysis, blood glucose is the most important factor for the fetal wastage. So we got the idea that means that fetal wastage occurs because of the glucose intolerance. Okay, we found it out. Then we published that data at that time, 1984, in the Journal of Obstetrics and Gynecology, where we discussed so many causes of the fetus. The top was this one. So okay, this was confirmed. Now we decided to tell, we told director, that means having understood that we must screen, imagine, government hospital means 16,000 births will occur every year. So everyone has to go through this. They said everybody should be screened. The government said, I said, where to go for money? 3 blood tests, 4 blood tests, those are 3 blood tests. O11 Mahan, the very popular test. They said, no, we can't help it. Then what we did, then what myself and Sundaram talked, Sundaram and Hariharan. Then we called spot test. If a woman comes in the empty stomach, we call it fasting. Then fasting, she says, I have taken some food half an hour earlier, okay, after 30 minutes, 1 hour, depending on the time the woman says. Like that, fasting, 30, 1, 1.5, 2, up to 3 hours, we'll test. Then we found if a normal person, the blood sugar those days was we didn't have that plasma glucose, whole blood glucose test was there. Then we found, then finally realized, normally blood sugar in the women do not cross 90 milligrams fasting or 120 milligram 2 hours after the meal. So that is spot test. It is a very popular test, spot test those days, like a single test. The spot test again was published in the Journal of the Obstetric Gynecology, and few people started following. But what happened? It is not a definitive test. Spot test is not a definitive test. See, if you say you have got a glucose tolerance, they said, how do you know that I got a glucose tolerance? Just by testing like this. Then only we started working again on that. Then we did the fasting, and then 2 hours after glucose, 2 hours tested, it became 140. Was it again? What happened? We had to do another step. First step, spot test. This other step was again a test procedure where fasting blood sugar has been done, then glucose has to be given, 2 hour blood sugar. So what happens? Woman has to come in the fasting state. Otherwise, the test cannot be performed. So he has to come again. So then we thought, what else we can do? How to make it simplified? Then that is time, I think, Anjalachi was my student. And then Sith Alexander was the director at that time of the Institute of Obstetric Gynecology. Anjalachi was one of the professors. Then I told them, this is very good people do this. Listen, I said, you do what this way. I told them, whenever a woman comes, give 100 gram glucose, irrespective of the last meal timing, again do the blood test 2 hours. Okay. The same woman, we asked to come again after 5 days in fasting, classical fasting. Then then he found those people who were supposed to have glucose intolerance, whether it is fasting or non-fasting, the blood sugar goes up. Where normal people, nothing happened. So that's why we suggested this test called do the single test procedure, whether it is fasting and non-fasting, irrespective of the last meal timing. That was again published in the Acta Diabetologia. So the number of query came when I sent that paper because it is something unusual for them. So you are telling fasting also is okay, non-fasting also, won't want to diagnose. Then I told them the whole talk depending on what depends physiology or metabolism that occurs in any person. So suppose a normal person, if he takes glucose, sugar will not go. Again add glucose, it will not go. Whereas if a person happens to be a diabetic, unknown, if you give glucose, sugar go up. If you glucose further, it is going up. So same thing in parents also. If she is normal, whatever glucose I'm going to give, it will not go. So if she is going to be diabetic, glucose given, it will go. That's called either she's fasting, non-fasting. It is going to it is going to will be able to diagnose GDM. So this was explanation given because what happened, Sunil, it took for me 1 year to publish it because the first goes on asking review. Then they're not convinced. How can you do the non-fasting test and say that it's possible? So after giving this explanation, then it was published in the Acta Diabetology. I was about to visit a paper. Then the reviewer said, Now, since you give the explanation, we will accept your paper. They can't publish. That's how acted after came. Then we were so happy that it isn't published. Then we can use this test for the public. So that then what happened? And now that they are convinced, then we wanted to go to the field. What happens in the field? What is the progress of GDM in the field? So those days, by the time I retired from the government service, I was not knowing what to do. Then what happened? Fortunately, this Stanford Medical Dean was officiating. I told him I want to do this study in there's one hospital, is the RSRM Medical Hospital, Women Hospital. They said permission you want to give. Then when we did this study, first time in the hospital, we found almost 14 to 15%, I think 50% of them had GDM, 15%. Then I couldn't believe, how can we so much? That is the area, not rich area. It is very, very absolutely poor area, you can say it, like a urban, semi-urban area. So that same time, Anjalachi was doing a study in the another hospital, and she also came almost with the same data. So I was convinced. That means she know, or I didn't know what she was doing. Then we found the same progress occurring. Then we are convinced. Then what happened? Having convinced, that is the time we want to know the field in the Chennai city, semi-urban area like called Saidapet area, then rural. So we want to give 3 areas. Then where to go for money. So that is the time Anil Kapoor, he was the WF, he said, this is what is happening. I want a fund from you people to screen all these people. And then we did the screening. Almost it took 1 or 2 years. 2,000 and odd people were screened. In the first, I think in the world, ours is the second most important screening done in the country. And if we compare, IPO study, hyperglycemia and prenatal study was different. Whereas Indian study, this is the only study so far nobody has repeated. That's all the only time done in the country. That's what we call Tamil Nadu model. In that, when it screened 12,000 people, we were again surprised and shocked. No, 16% of this women coming in the urban area had glucose tolerance. Whereas when you go for the semi-urban, it's 14%. When you go to the rural, 9%. That is the prevalence of GDM in those days. So this is again, nobody knows. The first time we are able to find out this what is happening. Then we told the government, fortunately, then the secretary was a very good fellow, Dr. Subbaraj. Mr. Subbaraj, he immediately gave the order called, he made mandatory screening for glucose tolerance in the mandatory. Because the first time government order was given to screen everywhere in the state. Okay, that's going on. Then
and that was the first time. That was for the first time in the country that Tamil Nadu state started this, right, sir?
Yes. Yes.
No other state had. Yes.
Pardon? Yeah. Okay. That's all. I thought my work is over. Almost done it. Then we started reaching everywhere. Then the Pandir Selvam would have seen he was sitting there. Vardhani was the Anthology. All these people, I asked them to go into the field and again talk to them, tell them what they should do. That is what is going on. That is how this came. And so happened, one of the Minister of Health government officer, doctor had a GDM. They also didn't know about that. What is GDM? This and that. Blood sugar they found a little higher. Then they found my paper and my Chennai's work. Then he thought, why not we make it the government of India? They called me. Then we went there. Then we discussed. We had 3 meetings, and then myself, and then few people from ICMR, the Munita Das from Lucknow. She was supposed to be the important lady for that. And the 3 consecutive meetings we had, finally we said what to do. That is what called National Guidelines for Diagnostic Video was published 2014. So we have got the Minister of Health government approval for this single test procedure that was going on. And then again, implementation was due. I said do anything in the government, implementation was given guidelines, but people are not following. So again, we insist on the government. 2018 would have seen the guide. Again, they published once more. After that, they left it like that. That is the government of India guidelines. So now it is up to the confusion comes among our doctors. Not, I don't think you blame the government. Some people just understand we have done 12,000 people and come to conclusion. These fellows do 300, 400 and said, no, they will, IDPG guideline is the best. IDPG, I tell you, the Caucasians or white people are very good people. They told me, your problem is different, our problem is different. Our guidelines is different because our population is different. We also proved what happened those days. The IADP, the International Study Group, they found they also didn't include India at that time. They all Caucasians. Only two places they had outside the Caucasian group, that is Bangkok and Hong Kong. There, what happened in the IDP they found, many of us know 92 milligram fasting was one of the criteria. And then they found these places, Bangkok and Hong Kong, they're not able to find out, only 21% had more than 92 milligrams. So they said, we will not go on that. So they said, they left it like that. And we also did in Chennai, only 24% only we could pick up with fasting. So then we said no. They said fasting is not useful. WHO also again gave the guidelines that pregnancy people fasting blood sugar has no use. They must go to postpartum also. Now, Sunil, the problem comes here. This IADP's guidelines is maybe good for the Caucasian, maybe good for us also, provided you do perfectly what they said. It is not any one value. Any one value is not correct thing what they said. You have to do the fasting blood sugar, whatever value, then detect that number from the total number, then 2 hours, 3 hours. Like that, it's process very, very difficult. So nobody, I don't think any Indian doctor did study like that. They just fasting is 1 hour high. They put together and they got through that, and then said no, 140 is a specificity low. Some I don't know much about statistics. I'm honest, I'm telling you. I don't. This statistics means I thought some maneuver we can do. So I was not approving the IDPG, and they also told my position in the world. I am still vice chairman of the IDPG. Still, I am vice chairman. That shows they know that I am honest in my work. They said, you be there. We don't want to bother about you. Whatever study you did, you publish it and do it again. So they are not interfering at all with our single test procedure. In your country needs, you do that country same procedure. We are following it. So that is how what we started as a spot test became a single test procedure for diagnosing GDM. That is a big story. I told you. Anything you want to ask, please tell me.
Got diabetes, and then because he was your mentor in the career, and then you entered into from a military kind of environment to the civilian's life, and still then not in the private practice but in the government setup. Doing in government setup such a mammoth work is seems to be little very, very difficult task, but still you can succeed. And we as a young generation people really get inspired. For one thing, the journey has not happened in a day. It took almost 3 to 4 decades.
Goes on.
So it took almost 3 to 4 decades to come out with this DIPSI test, and not just in 1 or 2 days.
Yeah. I think you were able to appreciate that. See, so many years, so many tests tested. Finally, we came to single procedure. So, as the Cartlin said, it has almost taken 30 to 40 years to come to a guideline which will be useful for us. Put number ways, and that's what we call evidence-based economic. All the tests. Then now these countries developing countries need simpler tests. If you read the article, strategies for diagnosing GDM in the DRCP, they said many people know what happens. Sunil, they'll come and say, yeah, we'll follow IDP. But when they go back, they fail, they'll know, oh, we are not able to do it. They'll say, no, we'll do it, but they won't do it. So that's what the comment is there. I got a slide like that. So fortunately, we didn't want to follow that type of false statement. We did honestly said we are not able to do that. We'll stick to our own guidelines. And David McIntyre, I know many of you know about him. He was the president of those days IDP. He said, I appreciate your population so huge, so huge. It is not possible for screening with 3 blood tests. Lots of problems with there. What your test is most simple, and do it.
So what is a message to a common man? Because this program is basically focused on the women to be empowered with good quality knowledge. And I feel in our inauguration ceremony, Professor, possibly Dr. Anil Kapoor or some of the speaker has said that women should now come of herself and asking you, have you done my GCT? Have you done my
Correct.
DIPSI test? So what is your take on this? How should we as a young generation should go ahead on these lines so that public can get sensitized? Now someone gets cough, people know that they might be having corona and they directly go to for RT-PCR or antigen test. Now similarly for pregnancy, I feel we have to be more aggressive. So what is your take? How should we be going ahead to the mass on this?
Yeah, I told you in my talk initially, all things starts from the womb. So most important is the pregnancy. So in the curriculum or school curriculum, particularly the girls, the school or colleges, they must have at least 1 or 2 hours of teaching what is pregnancy, what could happen, how should be kind of conception take place, what it should do if you miss the period. All these things must be told. So already they're tuned. This is what. Otherwise, they'll never understand because they'll never go to the doctor. Provided school children, so village, they will never go to anywhere. Their only way is to promote in the what do you call that? TV. TV must be, as I told you, the TV program must be. Your child's health is in your hand. So please test your blood sugar. In the moment you miss your period, go to the doctor. Tell him I missed my period, what I should do. And that is one. The another thing, doctor also should be aware that the blood test should be done. The problem is what 2 things must be aware. One, the women may not be aware that things can go wrong in the pregnancy because of glucose. They're not aware, not everybody. It's educated, they may not. They're not aware. The only way to promote in the publicity, that's what happens. What is the like HIV, like same way they know also for the pregnancy also. Then there also a lady, when woman is pregnant, all the doctors should have test is very, very simple for them. Instead of asking them to come to the fasting and go to the lab and do fast. And many of the lab people are at the fault because lab people want to make money. They say, no, you must do like that fasting or two. They never accept what doctors say. They will do whatever they want. So that is there lots of money wasted in there. And then many people may not go because 3 blood tests. She also can't go, and she go in the fasting blood test is not. And I think Dr. Bhavadani work I must quote. I never try to quote. In rural areas, if you ask the woman, if she comes to a woman for a blood test, honestly, she comes for the test. The doctor tells, no, you're not come in the fasting, so go back and come in 2 days. She won't come because their life depends on field. If the field lady misses one day income, they're lost. So they will not come. So what they should do, anytime they come, they must do. So the data shows 82% of women come to the antenatal clinic after food, not fasting. So you're missing if you don't go to the blood test. That is why this test has become very important and simple, non-fasting. Any woman comes there, test, I am in the family way, they give you glucose. Don't ask anybody, give a glucose and do or two. See, now we're not able to do anything. See, you can ask me, why glucose, why 2 hours? There's no other way. Because suppose if it tells a woman, you got a glucose tolerance or GDM, particularly people from some community in North, they don't like their daughter-in-law feeling they're getting a glucose diabetes. What? Because this is diabetes, they get annoyed. So where I got this daughter-in-law? Their question. And we treat that daughter-in-law badly, they may not treat very well. So that is why we said we must. I also told in my talk, the test must be definite. There is no question of doubt. So you have to give glucose. Without giving glucose, whatever value you give, it may not be accepted. So it is better to only one test, one glucose, one value. I tell this somebody our Samar was telling, Swamiji mantra. One test, give 70 glucose, do 140 milligram diagnosis, one test to 120 postpartum control. So only three steps. One glucose 75, second diagnosis 140, third control 120. What is big game in this? Anybody will know. Isn't it? That is if at all you teach this program, ultimately you tell them, please carry your message. This is what it should do. One test, one value, one diagnosis. This mantra all the time remember and continue promoting it everywhere. Probably, I'm sure if this program which you are planning, I'm very happy that you are doing this study program every month. Wednesday, excellent. You are talking, but how many people will listen? Something should be there. Some song must be there. Some actor. Another thing is, Sunil, what you should do, involve a popular actress to talk on this. 1 minute or 2 minutes, because they immediately listen to them. So what you doctors will tell that lady, I seen you talk in the NDTV. Which is good, but that is only educated people, but uneducated, they're not impressed by doctor's way they talk. You talk, and then some lady must be there to tell like this. So most important thing is promoting propaganda in the what we call TV, radio, all this. After one sentence, please, your child's health is in your hand. Go on, meet the doctor if you are conceived. So that is the only way it can do. Otherwise, don't make the complicated subject. Don't teach them medicine that time. Particularly ASHA workers, those working in the field, they should know what they should do, what are they supposed to do. You can't teach them 3 blood tests. I say, how can you do, Sunil? This is our doctors, some of them still talk about IED. I am not happy to. I just don't know how to do it. How to? No, not possible at all.
Yeah. Sir, you said, sorry.
No, countries like Pakistan, she had come to Chennai, Bangalore conference. They have found out this test is good, but somebody confused them. I know what happened. Initially, they are doing it. Somebody confused them. No, you must do IDPG. Some fellow, he's a rich man, he's a rich doctor. He can do. He unnecessarily polluted their mind. Then again, I spoke another meeting. Last year, Rajiv Chala was there. The South Asian, Middle East meeting. Somebody I told that in any country in this world, even America can't afford 3 blood tests. You can imagine the drugs are so expensive in America, they cannot buy it. And the test will be again the whole insurance. So for them also, I think the day will come, Sunil, when they start promoting this, I'm sure world will listen to you. It becomes
so nice. So nice. I think these are some golden words from your end.
Yeah, it is. My name is very difficult to the Seshiah's blood test. The most simplest will be Sunil's blood test.
It can never be that.
My name is difficult to pronounce. What is that? Go ahead. I see, after all, a bit like our children, no? Whatever we possess, we passed on. So that is the way, in spite of everything made simpler. So life will become simpler.
Yes, that's a simple test, one reading. I feel that's a simple way of living, and that's what it should be feasible. And it's very difficult to get people fasting state. You said one important statement: your child's health is in your hand. Now, can you just elaborate, sir, this, how a common man should understand this?
As a
Before
matter
we
of pregnancy could be planned or could be accidental. They get married, so they don't know that they'll become pregnant. They planned pregnancy is not very rare. It might be accidental only, so they're not aware at all. So you must all the time you must promoting the guidelines somewhere. Your child's health is in your hand. So they say, what do you mean by that? Yeah, if you become pregnant, you must keep your blood sugar, everything under control, diet under control, so that the child which is going to you deliver should not become illness. No diabetes. Same, you also will not become diabetes. So both they call dual transgeneric. So by maintaining your blood sugar normal, you may not develop diabetes in the future because others or most of the GDM will become type 2 diabetes. So by maintaining this blood sugar level within the normal range, you may not develop diabetes and the child, but they will be more interested in the child. So if you keep your blood sugar normal, your child's health is in the hand. So go a step to go to blood test must be done. As
So
I told,
I
that
feel,
blood
yes, yes. So I feel we have a lot of learning from this session, and the carry home message what I could get from Professor Seshiah for every one of us who's a part of this particular public awareness campaign. Sir wants to promote very important message here. Every woman, irrespective whether you
sales
have positive history, whether you don't have
this
positive
promote.
family history, irrespective whether you are obese or non-obese, irrespective of your age. Once you get pregnant, the first thing is that you have to go to your doctor and tell them that, doctor, I have become pregnant now, and please check my all every important test. In that, don't do just urine sugar, don't do just random blood glucose.
No,
One
no, no.
should do only and only 75-gram glucose 2 hour test,
Okay.
irrespective of the type of time of the meal. And then if it is 2 hours is more than 140, you call it as gestational diabetes. Sometimes you may get misleaded through a pathologist report when it mentioned as normal. That should be actually made into the conscious of your clinician, and then you should be treated. 70 to 80% of these women can do very well without any pharmacotherapy, without medicine, just that lifestyle modification, and control your blood glucose to a large extent, so that you can protect your child from developing diabetes in the future life. Sir has said,
80% of the women, though their
yes,
glucose tolerance GDM, may be controlled only with nutrition. There's no necessary for intervention. So it's
yes.
not a very difficult problem.
So the message is everyone should be screened. If
Yes.
your first screening is negative, at least do a second screening in the second trimester, and if possible third trimester. If not, at least 2 minimum screenings are must. That's what DIPSI and Government of India also recommends. Important. If you're detected to a diabetes, don't worry about at all. Just follow your dietitian, just follow your doctor, monitor your blood glucose, and you will be able to achieve good glycemic control, almost 80% chances. 20% may need some therapy. That's what is a message. So not to worry too much about diabetes in pregnancy, but one should always be very, very sincere and conscious enough to understand that this particular issue, if not remain addressed, if it remain unaddressed, if it remains undiagnosed, then it may create issue in the long term life of a child who is born to these mothers. One, and second, if you don't diagnose it, if you don't treat it, then it may affect the baby at the time of delivery, as well it may affect the baby in long term. These women, sir has also highlighted an important point. These women who have pregnancy diabetes after delivery, there is high chances, almost 50% of them in next 5 to 10 years are going to become frank type 2 diabetes. And that is why if you control diabetes well in advance, if you start following lifestyle modification, these women can be saved from developing diabetes in future. So he said intergenerational transmission. In other words, in a simple word, he has said the 2 generations can be protected, the child and the mother. So by just doing simple test, by just managing 80% of the women on medical nutrition therapy, just following lifestyle modification, 80% of these women can be saved with their children in future. I feel this is a very strong message to the society, sir. We are really overwhelmed to have you with us. And thank you very much for all your golden words. If you want to give a final message, one line, we can certainly take that. And
You are sending the chat box. Chat box.
It is in the chat box.
there are some questions in the chat box.
No.
No, the final message is in the chat box.
Have you written it?
Your child's health is in your hands.
Yes, that we have already said. Yes, very
You understand, but this must be the message to spread everywhere. And,
yes, sir. We'll take it up, sir. With the punchline of focus.
Your talk,
for people.
at the end, you say, this is what you should do. Your child's
Yes,
health is in your hand.
Yes. So, with your permission, sir, can we stop this session for the day
Why not?
and seek your blessings for future programs?
No, I'm very happy, Sunil. You have done such a wonderful work. It's very happy to be his president, for selecting you as a president of the Dipsy. And very nice, your wife Kavita, very well she support you, and good control of language. My God, very good she speaks. So I also admire the way she speaks. So let God bless you both and your family, children. So you legacy must continue. Let us see how it goes.
Thank you, sir. Thank you very much for blessings. And once again, heartiest congratulations that you have been conferred with this very prestigious honor of the country by President of India, Padmashri. We are really proud. And someone said that it feels that as if you have got the award, and the same feeling with the whole family of Dipsy have the feeling that that we all have been conferred with this honor, and we are so happy with you, sir. Thank you once again, and I stop here. Mosley, can we stop the